Good afternoon. Today's class is on epidemiology of malocclusion and various indices that we use in orthodontics. So first, what is epidemiology? So if we divide the word, epi means among, demos is people and logos means study. So basically it means study among people. So by definition, we can say epidemiology is the study of the distribution and determinants of health related states and events in a population. So why do we have to conduct these epidemiological studies? So first aim is to describe the distribution and the size of the problem in the population, to identify the etiological factor, to provide the data essential for planning, implementation, evaluation of the services for the prevention, control, treatment, and for setting up of priorities among those services. So ultimately, the epidemiological study is used to eliminate or reduce health problems or its consequences and promote health and well being in a population. So, when we are seeing this epidemiological studies, when we are looking for certain events in the population, we are looking at something called as prevalence. So, the term prevalence it is used to indicate what proportion of a given population is affected by a condition at a given point of time. So, among the entire population, how much population is having certain condition. So, that is prevalence. So, to know the prevalence of an event in the population, we can uh, plan different types of studies. So, broadly, it could be a cross sectional study or a longitudinal study. So, what is a cross sectional study? It is a simple study where individuals are chosen from a population and they are representative of that population. Suppose a certain state is having uh, 50% of Telugu speaking population. So, if we are doing some study on the language, so the study sample should have the same percentage of the Telugu speaking population. So, at a given point, randomly the people are selected from the population for a cross sectional study, and the study is done at that point of time. Comparatively, in a longitudinal study, uh, the same sample of people they are observed over a longer period of time. So it is a cross sectional study that is done for longer duration and they are repeatedly observed. So the problem here is it can be time consuming because it takes years to finish the study. So there will be many people uh, coming out of the study. So that's why it's difficult to organize and to periodically monitor the sample. So if you see the prevalence of malocclusion in different countries, uh, a common factor is the malocclusion prevalence is higher in developed countries. If we see class 2 malocclusion or dystocclusion, in India it is comparatively low uh, in comparison to USA, where 34% of white population and 15% of black population show class 2 malocclusion. And in comparison to Europe, 29% uh, population in Europe shows class 2 malocclusion. Whereas if we compare Indian prevalence to the African nations, Indian population has a tendency towards higher rate of class 2 malocclusion compared to Africans, where there is only 4.26% prevalence. Similarly, even class 3 is less prevalent in India compared to other Asian countries. So, between 1930 and 1965, in the US, the prevalence of malocclusion was estimated to be around 35 to 95%. So, this is a very broad range. So, why there is so much variation is because of different criteria amongst different studies for the normal. In the United States, the National Center for Statistics has conducted different surveys. So, in between 1989 and 1994, the National Health and Nutrition Estimate Survey 3 was conducted, where the irregularity index, prevalence of midline diastema of greater than 2 mm, prevalence of posterior crossbite, overjet and overbite and open bite were measured. And this was a very large study where both children and adult population were considered, and they were interviewed as well as physical checkups were done. From this study, it was noted that over half of the children between 8 to 11 years had well aligned incisors, and this percentage with excellent alignment decreased by age 12 to 17 years. 34% of the population had well aligned lower anteriors, and nearly 15% of adolescents and adults had severe irregularity of lower incisors. If we see the midline diastema, it was often present in childhood, almost 26%, whereas only 6% of adolescents and adults had midline diastema. Racially, if you see, blacks had twice more incidence of midline diastema compared to white population. The overjet of 5 of or more occurred in 23% of children, 15% in youth, and 13% in adult. So as the adult age is reached, the overjet is slightly decreased. Whereas reverse overjet, which was indicative of class 3, it was less frequent and only seen in 1% in children and increased in adults slightly. Severe deep bite of greater than 5 occurred in 20% of children and 13% of adults. Open bite occurred less frequently in about 1%. Deep bite was more prevalent in whites than in blacks, whereas open bite was more prevalent in blacks than in whites. So this is the graph from the survey where the incisor irregularity was considered. So incisor irregularity is nothing but the amount of crowding. So the extreme of greater than 10 crowding was seen in less than 10% of the population. Similarly, the extreme class 2 and class 3s were seen in less than 10% of the population. So if we come to the prevalence of malocclusion in India, again there is a broad range of 19.6 to 96.05%. Again, this variation can be explained due to the multi-ethnic population. And broadly, many studies had divided the Indian population into seven ethnic groups based on anthropometric measurements. So, what are these ethnic groups? The Indo-Aryans, who occupied the eastern Punjab and Kashmir. Scytho-Dravidians, they inhabit the hilly tracts of Madhya Pradesh. Manglo-Dravidians, seen in Bengal and Orissa. Mongoloids, mostly along the Himalayan region. Dravidians inhabiting the southern India, southern Bihar, and coastal Orissa. Aryo Dravidians confined mainly to northern India, and Turco Iranians along the frontier province. So, the factors that contributed to the extreme variation in the percentages of malocclusion or prevalence of malocclusion in different studies was because of lack of demarcation between prevalence of malocclusion in the population versus the frequency distribution of malocclusion among patients visiting the hospital, the sample size and technique amongst different studies, and inappropriate selection procedures like variation in age group, the sex, inter and intra observers, and objective criteria. So, if we see the photograph, these are different studies conducted in India. So, the first study in 1942 by Shori KL in Punjab gave an estimate of almost 21.7% of class 1 malocclusion, 27.2% of class 2 malocclusion, and 0.5% of class 3 malocclusion. Whereas Miglani, again a population from Punjab, showed the overall incidence of or the prevalence of malocclusion to be 19.6%. Tiwari A in 1965 took a larger sample in the same Punjab region, but the age group was 6 to 12 years, where the malocclusion prevalence was 37.52. Coming to southern part of India, like Trivandrum, Bangalore, ODP, the malocclusion percentage was slightly higher, 49.2, 51.5. But overall, in the southern India, the class 1 malocclusion was more prevalent, whereas in the Punjab studies, the class 2 prevalence was more. The prevalence rates again varied in different North Indian population studies also. So now coming to the occlusal indices. So what are these indices? An index is an objective mathematical description of a disease or condition based on carefully determined criteria under specific circumstances. So these indices have been developed to identify patients with treatment need, to prioritize their treatment needs, and to be useful tools in epidemiological studies. So these indices also we can again classify into different types. If we see diagnostic indices, mostly for diagnosing a malocclusion, like Angle's classification system. Epidemiological indices like Summers Occlusion Index, to know what the malocclusion is in the population. Orthodontic treatment needs indices, IOTN. So this is to see the amount of orthodontic treatment need in a population. Then orthodontic treatment outcome indices, that is PAR index or peer assessment rating index. And orthodontic treatment complexity indices like index of complexity, outcome and need, icon. So first, malocclusion. It is defined as any deviation from normal occlusion of teeth. So the teeth are in abnormal position in relationship to the basal bone of the alveolar process, to the adjacent teeth, and or to the opposing teeth. So that is intra-arch as well as inter-arch problems. So the methods of recording and measuring malocclusion can be classified into two types: qualitative and quantitative. So a qualitative index, so it is basically describing a condition. So it's a descriptive classification of dentition. There is no information of the treatment need and outcome, and it is recorded in all or none manner. So there is no uh, grading in this qualitative index, and it is useful for epidemiological studies. Whereas quantitative index, it quantifies the complexity and severity of the problem rated in scale and proportion. It is used to prioritize the need for treatment, and it minimizes subjectivity related to diagnosis, outcome, and complexity assessment of the orthodontic treatment. So if we see certain qualitative methods of recording malocclusion, as we told earlier, Angle's classification of malocclusion, where we have class 1, class 2, and class 3 molar relationship. It is devised as a prescription for treatment. Then Stellard's index. So here the general dental status, including some malocclusion symptoms, were recorded. No definition of various symptoms was described. The other classification by Profit and Ackerman. So this was a comprehensive classification where a five-step procedure was used to assess malocclusion. So in the first, it was alignment, whether there is spacing, well aligned or crowded arches. In second, profile was seen, convex, concave or straight. Then in third, the crossbite or transverse relationships were seen. In the fourth, the angles classification or the anteroposterior classification or anteroposterior discrepancies were recorded. And fifth, the bite depth or the vertical problems were recorded. So if we come to the quantitative methods of recording malocclusion, so early index was by Masler and Frankel, where the number of teeth that were displaced or rotated were counted. Then malalignment index by Van Kirk and Pennell. So here the tooth displacement and rotation were measured and defined quantitatively. Another index called as handicapping labiolingual deviation index by Draker. So Draker defined handicap as an extreme deviation from an accepted norm which may or may not actually exist. So in this index, seven features were considered. The presence or absence of cleft palate, presence or absence of traumatic deviation. The overjet was measured in millimeters and uh, noted. Overbite was measured in millimeters. Mandibular protrusion, open bite, and labiolingual spread. So the sum total of all the traits gives the score. A score of 13 and more would be considered as a physical handicap. Occlusal feature index by Paulton and Aronson in 1961. So here the measurements include lower anterior crowding, cuspal interdigitation, overbite, and overjet. Occlusion features were measured and scored according to a defined criteria. Then the malocclusion severity estimated by Granger in 1960-61. So here seven weighted and defined measurements were taken. So weighted in the sense not all features had equal value. Some had more value compared to the others. So that is a weighted measurement. So the overjet, overbite, anterior open bite, congenitally missing maxillary incisors, first permanent molar relationship, posterior crossbite, and tooth displacement were measured. And accordingly, six malocclusion syndromes were defined. First one being positive overjet and anterior open bite, then positive overjet and overbite, distal molar relationship, and posterior crossbite with maxillary teeth buccal to mandibular teeth. So it's more like a class 2 condition. Then negative overjet, mesial molar relationship, posterior crossbite with maxillary teeth lingual to mandibular teeth. This is more like a class 3 malocclusion. In congenitally missing maxillary molars, tooth displacement and potential tooth displacement. Occlusal index by Summers. So here nine weighted and defined measurements were taken. The molar relation, overbite, overjet, posterior open bite, posterior crossbite, tooth displacement, midline relation, maxillary midline diastema, and congenitally missing maxillary incisors. And accordingly, seven malocclusion syndromes were defined: overjet and overbite, distal molar relation, overjet, overbite, posterior crossbite, midline diastema, and midline deviation, congenitally missing maxillary incisors, tooth displacement, posterior open bite, mesial molar relation, overjet, overbite, posterior crossbite, midline diastema, midline deviation, mesial molar relation, mixed dentition analysis, and tooth displacement. So different scoring schemes and forms for different stages of development were also given. That is different for deciduous stage, mixed dentition stage, and permanent dentition stage. Treatment priority index or TPI index by Granger. Here, 11 weighted and defined measurements are taken. Upper anterior segment overjet, lower anterior segment overjet, overbite of the upper anterior over lower anterior, anterior open bite, congenitally absence of incisors, distal molar relation, mesial molar relation, posterior crossbite where maxillary teeth were buccal to normal, posterior crossbite with maxillary teeth lingual to normal, tooth displacement, and gross anomalies. So here seven malocclusion syndromes were defined: maxillary expansion syndrome, overbite, retrognathism, open bite, prognathism, maxillary collapse syndrome, and congenitally missing incisor. The next index by Salzman, handicapping malocclusion assessment record. So this consisted of measurements which were divided into three parts. The first was intra-arch deviation, that is within the arch. So here the missing teeth, crowding, rotation, and spacings were quantified. In the inter-arch deviation, the overjet, overbite, crossbite, open bite, and mesiodistal deviations were quantified. And accordingly, six handicapping dentofacial deformities were seen: facial and oral clefts, lower lip palatal to maxillary incisors, occlusal interference, functional jaw limitation, facial asymmetry, and speech impairment. They were measured. So this could be assessed only on live patients. Then the index of orthodontic treatment need, or IOTN index in short, by Brook and Shaw. So this index has two components: the dental health component. So this dental health component is again based on Swedish Medical Health Board index. So that is divided into 5 grades. So this we have to see on the models or the patients, that is we measure. So grade 1 usually means no treatment is needed, whereas grade 5 indicates the need for treatment. Then in the aesthetic component, we have a series of 10 color photos with different degrees of dental attractiveness. So grade 1 is more aesthetic and grade 10 is aesthetically worse. So if we see the table here, so grade 1 usually there is no variation in occlusion or displacement which is less than or equal to 1 mm. The dentition in grade 2 where there is little need for orthodontic treatment. So here the increased overjet of greater than 3.5 millimeters but less than or equal to 6 mm with competent lips at rest. There could be a reverse overjet of greater than 0 mm but less than equal to 1 mm. Increased overbite greater than 3.5 mm with no gingival contact. Anterior or posterior crossbite with less than 1 mm displacement between retruded contact position and intercuspal position. Small lateral or anterior open bite greater than 1 mm but less than or equal to 2 mm. Prenormal or postnormal occlusions with no other anomalies. Mild displacement of teeth greater than 1 mm but less than or equal to 2 mm. In case of grade 3 or moderate requirement for orthodontic treatment, uh, here overjet between 3.5 millimeter to 6 millimeter with incompetent lips at rest was considered. Reverse overjet greater than 1 mm but less than equal to 3.5 mm. Increased and complete overbite with gingival contact but without indentations or signs of trauma. Anterior or posterior crossbite with less than or equal to 2 mm but greater than 1 mm displacement between retruded contact position and intercuspal position. Moderate lateral or anterior open bite greater than 2 mm but less than equal to 4 mm. And moderate displacement of teeth with greater than 2 mm but less than or equal to 4 mm. In case of grade 4, where there is a great requirement for orthodontic treatment, so there is a increased overjet of uh, greater than 6 mm but less than equal to 9 mm. Reverse overjet of greater than 3.5 mm with no reported masticatory or speech difficulties. Reverse overjet of greater than 1 mm but less than or equal to 3.5 mm with reported masticatory speech difficulties. Anterior or posterior crossbites with greater than 2 mm displacement between retruded contact position and intercuspal position. Posterior lingual crossbites with no occlusal contact in one or both buccal segments. Severe displacement or teeth greater than 4 mm. Extreme lateral or anterior open bite greater than 4 mm. Increased and complete overbite causing notable indentation on the palate or labial gingiva. Patient referred by a colleague for collaborative care, example periodontal restorative or temporomandibular joint considerations. Less extensive hypodontia requiring pre-restorative orthodontics or orthodontic space closure to obviate the need for a prosthesis. Not more than one tooth missing in any quadrant. So that indicates a great requirement. Whereas grade 5 or very great requirement for orthodontic treatment need. So defects of cleft lip and or palate, increased overjet greater than 9 mm, reverse overjet greater than 3.5 mm with reported masticatory or speech difficulties, impeded eruption of teeth with the exception of third molars due to crowding, displacement, presence of supernumerary teeth, retained primary teeth and any other pathological causes, extensive hypodontia with restorative implications, that is more than one tooth missing in any quadrant, that require pre-restorative orthodontics will come under grade 5. So this photo shows the aesthetic component where 10 pictures are displayed. So the 1 to 4 indicate no need of orthodontic treatment, 5 to 7 indicate moderate need, and 8 to 10 indicate a definite need for orthodontic treatment. Then the peer assessment rating or PAR index given by Richmond. So it measures the orthodontic treatment outcome. So scores are assigned to various occlusal traits that make up a malocclusion. The individual scores are summed and the total represents the degree to which a case deviates from normal alignment and occlusion. So the PAR index includes the scores of 5 individual traits, that is upper and lower segments, right and left buccal segments, overjet and overbite and center line. So the raw PAR score is calculated by adding the individual components of the PAR score. Weighting is attained to various components to get the weighted PAR score. The improvement in the PAR index can be assessed with either the point reduction in the weighted PAR score or percentage reduction. That is, initially we have a score and after treatment we have a PAR index score. So that gives the treatment outcome. So this is a scale with the measurements directly on it. So with the help of the scale, the different components can be measured. So this is the weightage given to different components and the total score is added. So to conclude, malocclusion is not just an invariable disease state but a continuous spectrum of occlusal variation occurring as a myriad of combinations and permutations of a number of heterogeneous traits or symptoms, each within its own wide range of severity and implications in creating a particular manifestation of occlusion. A good method of recording or measuring malocclusion is important for documentation of the prevalence and severity of malocclusion in the population groups. This kind of data is important not only for epidemiologists but also for the training of orthodontic professionals. Thank you.